challenge of recurrent pancreatitis in kids, I realize that there are a lot of non-specialists, so I'll make it very simple. So pancreatitis is inflammation of pancreas with clinical and pathological reversibility. That is the key word to know. And acute recurrent pancreatitis, the only difference is that it occurs 2 or more times. The same acute pancreatitis, which is 2 or more times, that is what you cause. And we realize that almost 15 to 35% of the children can have recurrent pancreatitis from the previous data. However, the INSPIRE study, which there were some talks from the plenaries, they have talked about this study, which is coming from the US, where they've talked, and they defined it as 2 episodes with resolution of pain in between, irrespective of the time period. There should be normalization of enzyme. And chronic pancreatitis, this is to remember for youngsters, even for the first time, if somebody comes to you with pain abdomen, but there are gland or duct changes, then it will be chronic pancreatitis. So chronic pancreatitis, the key thing is imaging finding, which is suggesting some abnormality in the duct or the gland. So this study, which is beautifully highlighted, 26,000 children who were admitted with acute pancreatitis in a national healthcare database from 2002 to 2014. In that, 10,000 plus were index hospitalization, which means acute pancreatitis, and 42% had rehospitalization, that means acute recurrent pancreatitis. This was more than what was known to us earlier. We thought 15, 30, but this study on such a large cohort quoted as 42%. So what did they learn from this study? 1 in 10 acute pancreatitis need ICU care. Overall mortality was 0.4%, which was less than the previous studies that were quoted. And I would like to highlight that children tolerate acute pancreatitis, including acute necrotic pancreatitis, much better than the adults. And the mean length of stay was 4 days. And acute recurrent was 42%, and they were seen in a median of 3 months or so from the first episode. So what is the pathophysiology of acute would also go same for recurrent, and there will be one difference which I will highlight. So whatever is your primary event, whether trauma, infection, metabolic, that will give rise to premature activation of the digestive enzymes, microvascular injury, leukocyte migration, release of cytokines, oxidative stress, leading to damage of the gland directly, pancreatic edema, ischemia, necrosis, and thrombosis of the vessels. So if you read this carefully, you will understand all the complications that occur in acute pancreatitis. Because of this, there is necrosis of the gland, release of the enzymes, and thrombosis of the vessels. So they spread to the peripancreatic space and systemically, leading to local complications and multi-organ failure. So what are the symptoms? Abdominal pain is the main symptom which you see in the epigastric or the left upper quadrant, radiating to the back in half the patients, and more after meals, and the child typically goes in the knee flexed position to relax. It would be associated with nausea, vomiting, poor appetite, fever, etc. If you have complications, that they may present to you with dyspnea, drowsiness, seizures. So whether acute or recurrent, what is the signs that you would see? You would find localized tenderness in the epigastric region, rigidity, rebound tenderness, and when there is ileus, there could be decreased bowel sounds, and usually because of collections, you might pick up pleural effusion and ascites. When there is complications, and this is something which is very important because acute pancreatitis in children is underdiagnosed, and therefore you need a high index of suspicion, because these symptoms patients are thought as multi-organ failure, sepsis, shock. That's how they are considered into it. So look for these signs. They may also have pancreatitis. So the immediate complications, we usually look for the metabolic like, sugars, calcium, potassium, acidosis, etc. And then this is what is the key management of the patient, where you are looking for circulatory failure. And I will give you one slide after this: respiratory, renal, neurological, hematological, gastrointestinal. So this patients, and late complications would include the infection of the necrotic pancreas, because it is full, it's like a material for the bacteria, the enzymes and all that could be there. And you can have abscess or pseudocyst, which is the commonest complication, and less frequently you might develop portal vein or splenic vein thrombosis. And this type, which gives rise to portal hypertension, we call it as compartmental portal hypertension, which you might see. You will not find any collaterals during that time, because it would be an acute thing. With later on you might end up with pancreatic insufficiency, exocrine or endocrine, depending on the extent of necrosis and the extent of pancreas that is damaged. God, whatever He has given you one organ, whether liver or pancreas, you think He's given you one, but it is more than 50%. So whichever organ is one is actually working twice as much. So let's start with this 14-year-old boy, which presents with intermittent abdominal pain for 3 days with vomitings. On examination, there was tenderness in the upper abdomen, and the child was overweight. And the investigation showed lipase 3461 and amylase 72. For the youngsters, let me remind you, amylase is the most frequently used biochemical test, but it's more than 3 times is which is sensitive and for picking up pancreatitis. But remember, it rises very quickly, 2 to 12 hours, but it also drops down. So you may see a patient like my patient on the 3rd day, the patient is presenting to us, so the amylase may not be raised because it falls down early too. And if it is persisting, think of pseudocyst, and you get amylase isoenzymes which are specific for the pancreas. The others could be including the other part. So lipase is more sensitive and specific than amylase, and 3 times above normal is virtually 100% sensitive and 99% specific that you see, and it rises a little later. So maybe if you pick up in the first few hours, it may not, but it decreases over a week or so. So that is the one which you might find it more raised. And this is again a message to the youngsters: levels do not indicate severity, because I have people telling me 8,000 lipase, but now it has come down to 800. So it's not the severity is not based on that. So what should I do? I should shift this patient initially to ICU. Once stabilized, then I should take to the ward. I should be looking into the vital monitoring, cardiovascular, pulmonary and renal monitoring. A word about this, if you get time, please read this paper which has come in the NASPGHAN and JPGN 2018, which highlights that you need to give 1.5 to 2 times maintenance IV fluid and ensure your urine output. And for pain management, opioid or non-opioid pain management. So looking at my patient, CRP is 313, but note procal is not very high. Counts were okay, renal tests are okay, blood culture no growth. There was a colon cutoff sign on X-ray, therefore we do ask for some X-ray abdomen. First line of investigation is ultrasound, which was suggestive of pancreatitis, but the fever is continuing for 3 days. Where the fever could be due to just inflammation and not necessarily infection, because majority of you all would get very nervous and jump to giving high-ended antibiotics in those conditions. So therefore I was highlighting. So in this patient, we went ahead with the CT scan, fever was persisting. So CT scan showed 40 to 50% pancreatic necrosis with peripancreatic fat stranding, hypodense fluid tracking into the greater sac, perisplenic, perihepatic, paracolic gutter, thickening of the renal fascia, perinephric and pleural effusions left more than right. So what do we do on CT scan? There are 2 types of scoring, Balthazar and modified CTS. Balthazar, you look at the organ A, B, C, D, E, and based on the necrosis, you give a scoring out of 10. And people in adults have shown that 9 to 11 had a very high mortality. But we presented a paper in one of the World Congress where we showed that children tolerated, and even with a score of this, we had only less than 1% mortality. of that. In modified CTS, so my child was fitting into 10 out of 10 because as you can see, you look at the pancreas, you look at necrosis and extra this thing. So the score of our patient was 10. Now tips on imaging, first line is ultrasound. I do see patients coming to me day 2 of pancreatitis with a CT scan report. So my dear colleagues, please, if you think of CT scan, it would not be appropriate to do it so early because it takes time for the inflammation and all and the changes to come. So ideally, postpone it to 96 hours after the onset of symptoms, and ultrasound does give you a good predictive. In fact, in mild pancreatitis, your CT may be normal in 15 to 30% of the cases. So this child, should I give IV antibiotic? So as I said, CRP was just an inflammatory marker, and the counts and all were normal. We just sat on it. We did not give any antibiotics. So you should give only when there is infected necrosis, and when you think it is infected, then you should give the ones which penetrate, and usually imipenem and Oflox have been said to be good. Most important thing is nutrition. Key message, in nutrition you should look for oral or enteral. If there is pain on oral, put in an NJ tube. So what did I do? I put in an NJ tube to this patient to give nutrition. Parenteral is very rarely indicated in patient with ileus. Earlier on, majority of the centers used to give parenteral, but now the guidelines are to use enteral nasojejunal tube for parenteral because it will also give rise to better healing and early and short length of stay. So my patient, I discharged on day 9 and followed up in OPD, and 3 weeks later the ultrasound is showing pancreatic pseudocyst. I told you pseudocyst is the commonest complication, 30% of them. When to intervene? 666 is all gone. There's nothing like 6 now. We just say intervene when symptomatic or the thing is infected or persistently non-resolving. Nowadays, you don't go in for surgeries. It is endoscopic intervening. If there is a massive one, you go endoscopically and put a cystogastrostomy or duodenostomy, depending where your bulge is. But in my patient, the ultrasound showed resolution, so we did not do anything. You just follow up and see how the patient is symptomatic. Now, same patient 9 months later comes to me with pain, abdomen, 2 days, vomiting, tenderness, and lipase amylase raised. So what is this? This is acute recurrent pancreatitis. So who have risk factors? Younger age, more severe index episodes of pancreatitis. But besides that, this paper of JPGN highlighted beautifully in 155 patients, 111, 72% had one of these. Either genetic, obstruction, toxic, metabolic, or autoimmune. This is what they would have and which you need to highlight. These are the patients who will have higher predisposition. And this paper was talking about their genes, and there were 2 presenters in the hepatology session who talked today coincidentally about Indian genes, and they said that CFTR, which was commonest here, 34, was not seen, but the other 2, the PRSS, PINK and CTRC, were also reported in the Indian papers that they were quoting for. Besides that, the obstructive was 33%, like whatever divisum, gallstones and biliary cysts and toxics, medications, etc. have been common. These are 2 slides which I will go slowly. The international multi-centric study. This is the largest characterized cohort of children with acute pancreatitis and CP, and it is the first observational study comparing these children of ARP getting into CP, which is chronic pancreatitis. Majority of the children with chronic pancreatitis described a prior history of acute recurrent pancreatitis and tended to be older age, suggesting that ARP and CP are a disease continuum. However, when I was studying in 80s and like 90s, we were told that these are 2 separate. It was David Whitcomb who was trying to show that probably this is a continuum, and over the next 2 decades, we have shown that this is the same insult, the primary which I talked about, in an underlying genetically predisposed, which was not understood 15 years earlier. We never taught this. So this clustering of these 2, the PRSS and SPINK, they are the one which predisposed to chronic pancreatitis. And maybe that if you look into early intervention of acute recurrent pancreatitis, you may progress. So what do you mean by early intervention? Identify choledochal, identify anatomical, identify APBJ, and this pancreatic divism, the previous speaker highlighted, we are not really sure whether all of them is there. Sometimes patient comes to you with just an acute first attack of pancreatitis, but if you take a good history, you realize that 7 years patient was admitted with some pain, appendicitis, and 4 years and 3 years. All these admissions he was not organized. So even on the first time you can call it. So we went ahead to do a MRCP and then you follow. And sometimes this patient CT is reported normal, but he gave us 6 to 7 episodes. So you should do MRCP because MRCP highlighted ductal strictures for which a stent was put across to relieve the pain. So we presented our data on ERCP in the World Congress earlier. Aneurysms is something like a large, big aneurysm, like 2 centimeter plus can happen sometimes, and you can put in a stent across, as you can see, and tackle that aneurysms there with interventional radiology. So our data in this last 6 years, again we showed that 17% were recurrent pancreatitis. We presented a lot of papers on pancreatitis, as you can see, RCP, and in the last 2 years. To sum up, acute pancreatitis needs a high index of suspicion. Serum amylase more than 3 times normal is 100% sensitive and 99% specific. Ultrasound is the first radiographic study of choice. CT is reserved for imaging, for understanding complication and prognosticating. Ideally, postpone it for first 3 to 4 days. Pseudocyst is the commonest complication. Only treat the symptomatic cases and not the size that you think. 30 to 40% of the children now we understand of acute go into chronic pancreatitis, and we also understand that high risk factors for acute recurrent pancreatitis is younger age, severe index episode, genetic factors, toxic, metabolic, and autoimmune. We've also understood that acute recurrent pancreatitis is progressing to chronic pancreatitis, and especially these 2 mutations are more common. So do investigate, and I have not spoken a word of EUS. I reserved it for the next speaker. MRCP, ERCP, genetic study. Will early intervention in acute recurrent pancreatitis prevent progression is what needs to be looked into in the next 1 or 2 decades. Thank you for your kind attention.